Hello, and welcome back to the Out of Program podcast. Today, we're joined by Dr. Dom Pimenta, a cardiologist, researcher, and health tech entrepreneur. He is the co-founder and CEO of Tortus, an AI health tech company building an intelligent ambient voice interface for clinicians, founded at Entrepreneur First and backed by Khosla Ventures. Hi, Dom. Welcome to the show.
Hi, Jink. Well, thanks so much for having me, and that's a great intro. I'll steal that next time. It's very concise.
You're more than welcome. So let's dive right in, and we'll start with your early career. So what originally drew you to medicine, and what were those early years like for you as a junior doctor?
That's a really good question. So I decided I want to be a doctor before I could remember why. So I think I've always wanted to be a doctor. I grew up in quite a sort of Catholic family, so we talked about death a lot, which is really funny now. I'm a parent, as I wouldn't say half the stuff that my mum said to me. Like, we used to pray that we wouldn't die on like an hour car journey every time we got in the car. And I was just like, that's totally normal at the time. But you really grew up in that environment of like, okay, well, this isn't it, right? So what happens in the afterlife is what it's all about. So what can you take with you? And my genius idea was, well, you can't take any money or stuff, so that's not worth pursuing. But if you're a doctor and you help people, then you might see them in heaven, and that's credit that you can buy later. I think that was my cynical 4-year-old brain. And I'm very much of that mindset. You make a plan and you execute it. So I just did that. So I went to, did the GCSEs, applied to medical school, kind of got rebuffed as most junior doctors, potential medics do, when they realize that actually, your aspirations and you've walked every class so far, but actually at some point you're going to hit the real world. And that definitely happened to me. But I went to UCL. I was there for the full 6 years, so integrated and beyond. Really enjoyed that, and thought that was very much a good life choice. And something about the tribe, I think, of medicine, I always found quite home in that sense, which is quite interesting. So my dad's Indian and my mum's Irish white, and we grew up in a very white part of the country. So interestingly, always felt a little bit othered, a bit of outsider, which is quite a common trait, I think, in lots of entrepreneurs. Medicine was like the tribe, right? This is my tribe. This is the arcane knowledge. These are my people, and really felt like being a doctor was sort of that end journey, complete identity of where I've always wanted to be and always wanted to end up, as well. Actually, I did end up. And then to answer your question about the early years of being a junior doctor, I think like we all experience is just like, why didn't they teach me to type? Like, do you know what I mean? Like, it's such a chain. You learn all this stuff, and then you come in to be an F1, and people are dying in front of you, and no one's really prepared you for that because you're responsible now in a way. And I'm sure most of the listeners will recognize that, but I'm still relatively in touch with most of the people that we did F1 with, because you were all on the trenches together and all crying, and the trauma and the fun and the getting really drunk, which was a big part of that. Lots of people put a lot of weight in F1, never ask why. So you're just drinking so much because you have to cope with it somehow. So we did F1 and F2 in the Oxford Deanery. It was at Wexham Park. This was going back, I don't know, 10 years now? God, time does fly. And yeah, it was pretty intense, to say the least, but really enjoyable and a big step up. And you get exposed to the politics and all the stuff that you don't really think should exist. And then you're like, oh, actually, people just do things because they're not very nice people, and it's got nothing to do with medicine. And then I think early on had decided that medicine was for me. I did want to be a surgeon for a while, but sort of changed. I kind of really liked the medicine, the diagnosis side, and got really into that, especially at Oxford. And then came back to do CMT at UCH, and eventually became a cardiology reg, and was at central London rotations for most of that time. But I think each step up was quite new and exciting. And I remember the first time, sort of, when you do your SHO ward round, that's like a big step up. And then you do your CMT ward round the first time you hold the bleep on take, and all these moments of like, oh yeah, actually I do know what I'm doing. And then COVID came, so that was a sort of sea change moment, and I went from relatively senior cardiology reg to COVID ITU, and kind of really not really knowing very much. I mean, you kind of know a bit about ITU. It's not a massive leap, but like it's quite a massive leap in many, many other ways. And that was really interesting again, because it was something new and something different. And then that was sort of sort of one of my jumping off points, I should say, into something different.
And before we get into all of that, I suppose just exploring that journey from being a student to then a junior doctor and then to a specialist. It sounds like a very classical kind of pathway and description that a lot of clinicians would describe. But was there any points early on where you were exploring alternative paths or had an inkling that you wanted to do something different?
Yeah, it's a super good question. And I think in the retrospect, so if you flash forward a few years, I mean, Tortus was founded out of Entrepreneur first. That was about 3 or 4 years ago. And when I was applying for it, I looked at the criteria for what they were looking for. And it was like people who were disruptive and
Mm.
always kind of like doing things at work and kind of getting into trouble for
Yeah.
doing. And
Mm.
actually, it was weird because when I looked back retrospectively, that was always my issue. For example, in the very first year of F1, we rocked up to this hospital, which now shall remain nameless for this podcast,
Oh, of
and they were
course.
recording the acute take, the list for the medical take, on a bit of paper. And 3 times in a 4-month rotation, that bit of paper got lost.
Mm.
And suddenly we had no idea where the sickest, newest patients who haven't been reviewed by a consultant yet are in the hospital. We've just lost them. And I was like, but this isn't, this isn't 1984. This was like 2012. And really, like, we had Excel and we had email and we had all these like digital tools. And I was like, why don't we have a Google Drive where we just have a shared document? So basically what happened was we sort of went, okay, well, we know there's a digital system using take. We've just used it in surgery. So let's go use it in medicine. Let's just start doing it. We started doing it, storing the take. We audited it. We took it to quite a far degree. We had some buy-in from the consultants to do it. And then what boggled my mind was IT came down and went, no, you can't do this. Take it all down, cancel it. We can't do this. And the consultants were like, but why? Like, it's working, it's already, and it actually transpires that other system was not something IT were aware of in their own hospital. It was all mad. But it was really interesting to see how much friction that produced. Something that was so obvious and so needed, and we just did it. But what was interesting to me is like that piece of you just did it, right? If you're one of those people that's like, I'm just going to go do this and see what happens, that is a quality that's actually not very helpful for you in that traditional medical career, because you're always just like,
100%.
the troublemaker in the back of, oh,
Yeah.
why didn't they help, right? So I actually spent a lot of my time and even had like chats about career guidance with people in other industries about how I could navigate better and just basically just shut up. And I really struggled with that. And every time anything was like obviously wrong or easily fixed or there was a patient issue, I was like, why don't we just do this? Or why don't we build this? Or why don't we have this process? So always like picking at the system and going, oh, this could be better, which I never really thought anything of other than that's obvious. I remember another time I was in ITU at UCH, and we had these tiny screens, but quite complex patients. And over here, someone had like just got all these random computer screens, and some of them were widescreen. I was like, oh, that's interesting. So we set up a terminal overnight, 2 widescreens back to back, so you could basically look at a patient's observations, blood test results going back to like a month or 2, as opposed to a week. And suddenly we saw all these patients like, oh, actually, that's an anemia. That patient's actually in liver failure. This person came in with a normal creatinine and we just missed that. And now they're also in renal failure. And all these new diagnoses came out of having this data. And we're like, oh my God, we've just revolutionized this whole ward by just having like this blood review system. Came back in for the night shift the next day. IT had come down, taken it apart. They were like, we didn't put that together. Take it apart. And we were just like, but why? Like, it worked. It's your components. It was just sitting there. And there was so many times along the way where we tried to implement or do something, and then the politics of whatever it was or the bureaucracy, and that was so infuriating to me. And I remember like lots of people counseled me at the time, like, you got to play the game and keep people sweet. And I was just like, I just can't. I just don't work like that. I just don't want to do that. And then what was interesting to me was when COVID came and suddenly kind of all the gloves were off. Nobody kind of knew what to do. We just needed to do things. And everybody was basically being paid to be at home and couldn't help. So actually, as a recruitment pool of basically everybody in the country, so it was a great time to start anything, really. And that was very lucky because obviously now in the retrospect, I know how hard it is to recruit, for example, and get people on your team. So when we founded a charity during COVID, and that was my first founding experience, but suddenly all of those negative qualities
Mm.
were positives, like bias to action, just get on with it, we'll figure out some of this later, managing the risk that you can manage and accepting the risk that you can't. And a lot of that isn't traditional. But if anyone's listening to this and they're like, yeah, I got a lot of trouble as a troublemaker, or was like disruptive in X, Y, Z career, or I annoyed all these consultants and I didn't get a job there, you're probably actually somebody that would benefit from starting your own thing. But for medics, it's a very big leap. So, as you know.
Yeah, I think you really hit the nail on the head in terms of like some of the early personality traits or characteristics that predispose a person to becoming an innovator. Because from your story, what is clear is that you really enjoyed medicine. You went on a very traditional kind of pathway to do so, but you were constantly questioning the status quo. You were an agitator. You butted heads with the authority, and to your point, that was viewed negatively pre-pandemic, but once all the red tape went out the window and we all needed to do things differently, that was when it was your time to shine. Now, you mentioned around co-founding the charity, and I want to get to that in a moment. But before I do that, I also wanted to touch upon some of the things that you've mentioned before, which is around a love for making things. And I believe you explored coding, Python, AI quite early on in your career. So could you share a bit more about that?
Yeah, so I mean, I got to the end stages of cardiology training. I done all the subspecialties, so electrophysiology, intervention, heart failure, grown-up congenital heart disease. I liked them all, but I didn't love any of them, and that was a big
Mm,
red flag because you have to pick one and then
mm.
do it for like 35 years. So problematic. And my actual plan, which kind of shows like, not necessarily thinking outside the box at all, was like, I don't want to make this decision now. Let me go do a PhD and I'll figure it out in 4 years' time, which is what a lot of London Reggers actually do. And so my plan was, I think AI is pretty cool. Let me go learn how to code. I'll do machine learning and cardiovascular science. It's still a great idea. So my original thesis idea was build a multimodal model that would basically replicate what I was doing every day when I saw new patients on the cardiology referral. I had a chest pain rubric, so I'd always ask the same 5 questions. Depending on those answers, I would do 1 of 5 actions. And it worked really well, actually. It was a very, very consistent system, and consistency I realized was pretty key. But the other thing I would realize is there was just a lot of what I would call human pattern recognition instead of thinking. And that's actually where a lot of ethnic minority groups and women
Mm,
especially are underdiagnosed for NSTEMI, simply because the pattern doesn't fit what the human expects. But actually the AI models can see, because it's all delta, it's all relative numbers. So for example, women have less heart muscle, therefore the troponin rises are less significant, but actually reflects the same area of ischemia as a man.
mm.
But the delta's, oh, it's just a small, troponin rise is barely 20. And I was like, that's actually massive depending on your size and the relative, timings of that. So an AI model could bring precision in a reliable way to an area and upskill, which is constantly something I think about, not necessarily raising the ceiling for the expert, but raising the floor for everybody else. And I think that was a really interesting mentality. There's so many gaps in medicine where AI actually could fill really well. So I learned to code and did a bunch of machine learning courses on Coursera. It's a good recommendation if anyone wants to sort of get their hand in. And I have to say, one of the hardest things I think I've ever done in my entire academic career was try to learn to code just de novo. Because the curve of learning is so high. It's so different from anything that you've done before if
Mm.
you've never touched a computer in that way. Um, and it was really interesting because about 3 or 4 lessons in, and I remember doing one and I was crying with tears of frustration, which is so funny now, but I just didn't clock that there's 2 types of slash on your keyboard. There's a forward slash and there's a backslash. And Python is in those days before vibe coding, Python is
Yeah.
very unforgiving, right? 1 backslash is a forward slash, your code ain't gonna run. And I just couldn't work it out. And I was literally just trying every single character. And I spent 3 hours at night, like in actual tears, or like, why can't I do this? Am I stupid? And then the other thing it required was lots of math, because there was loads of math in there in terms of, calculating matrices is a really big part of lots of machine learning models. But once it started to click and you started to follow and actually start to understand and actually started to run like gradient descent and a bunch of these other basic machine learning model types, I was like, oh my goodness me, like I can tell a computer what to do without software. Like it just do things. And then it's so funny because I say this to the engineers in the company all the time, and they just go, yes, I've known that since I was like old. But it was a real revelation that I was like, oh no, I get it. Like all of this potential to code is not just some geeky thing over here. It's about actuating your idea with the tools and the understanding at one level deeper. And obviously, if you want to write in binary, you can go all the way down to the kernel. And I just thought that was like that was like a light bulb moment for me. Like my ChatGPT moment before ChatGPT was, oh, you can like type in and do stuff. And I didn't get too far with it, to be honest, because I started to apply to various programs. Again, they are now renamed nameless, but I did apply to one very prominent AI program, and they gave me maybe the harshest feedback I've ever had. They said, this person is very unserious about artificial intelligence. And I'll show you unserious. And flash forward, I am now officially the first AI consultant in NHS history. Although, I mean, it says it on my badge, it's not an actual job, but it is like there. And I need to go find that professor, but he's probably forgotten all about me because that's what always happens. Like it's a massive deal to you and they just like don't care.
Yeah. God. You've got a real Count of Monte Cristo moment to fulfill.
That's a good reference, yes. Yeah, exactly. Except in that movie, everybody knew who that person was, and in this movie, they'd be like, "Who are you?" And it's like, "Oh God, it never cared."
I think in anyone's kind of career, as you're trying to make it, you put yourself in uncomfortable situations. And of course, you face a lot of rejection. Like, in the journey of patchwork, faced countless rejection. And I always used to think to myself, I'm going to prove you wrong. I'm going to do the thing that you thought that you thought I could never achieve. But as you've pointed out, the reality is that they don't care about you. They've completely forgotten about you. You could turn up and say, aha, I've made it. And they would have no idea of that interaction from those many years ago. But it's a nice psychological driver, I think.
Yeah, I read something, it comes with maturity as well. I read something that really resonated. It said in your 20s, you care what everybody thinks. In your 30s, you don't care what anyone thinks. And in your 40s, you realize no one ever thought about you anyway. And it's so true because like really no one thinks about anyone for more than 1% of their working brain anyway. So, and that's a really interesting thing about rejection is like, if you flip it on its head and you say, I just need 100 no's and then I'll get to the right answer. Every no gets you closer. And the corollary of that is like all these people think of this, they don't think about you at all. They've just given you an answer. They're probably wrong themselves and off they go. And then that becomes the fuel, as you say. But did you ever watch that Michael Jordan documentary?
The Last Dance.
Yes. Yeah. So there's a bit in that really resonated with me with that. So he had this mentality that he would very deliberately incite in his own brain that he'd somehow been majorly slighted or dunked on, or that guy's got it in for me. So he could generate that revenge thought process artificially. And I do think actually, having said everything, it is very valuable to have that revenge mentality, even when it doesn't exist, right? Even when, that guy, that professor, whatever it was 6-7 years ago was like, oh, still thinks about me. No, he doesn't. And I know he doesn't. But like the revenge of that, of like, well, I'll show you, is so motivating. And it drives you through a lot of walls, which otherwise, you would just stop at if you were reasonable. That's another funny thing that someone pointed out to me. They said, oh yeah, lots of entrepreneurs, innovators are visionaries. And I was like, I think actually the total opposite is true. The definition of an entrepreneur is actually someone who has a great idea and then cannot bring themselves to think of it ever failing. So they can't see it, right? They cannot see the brick wall and they just go through them all anyway. Because if someone actually said, look, this is what you're going to do and these are all the terrible, horrible things and all the lows that you're going to go through, no rational person would ever actually go, okay, let's give that a crack. They can't see the future at all. And that's exactly, they're almost like the opposite. They're like literally blind to how all these failures are going to hurt. And you just do them anyway, because you're kind of like blockheaded in that respect. And that's almost like the trick to it is to know that it's hard and it's going to be rubbish and just to do it anyway. But then, you need something to drive you through those walls. And I think revenge is a great one.
Yeah. I mean, that's great advice. Just engineer the chip on your shoulder so that you can then overcome all your obstacles.
Yeah.
So let's now talk a bit about the charity that you founded. What was the motivation there, and how did that all come about?
Yeah, I mean, again, when we talk about innovators' journeys, like some people are very planned, and I have always been a bit of a chaos engine. So COVID swept up in February, whatever it was, 2020. And at the time, I got very vocal about it being probably quite a big deal. It's built a bit of a following, and then it transpired as we went to intensive care that we were very understocked in terms of personal protective equipment.
Mm,
But also what was very interesting is, again, like there was a real lack of like time to do the math during COVID, and people don't think in exponentials very well. So you really had to sit down and do the math. I remember being on the ward in like late Feb, and we had one COVID patient on the ward, and I sent to the SHO and I said, this ward will be full of COVID
mm,
patients in 2 weeks. He's like, well, how? We've only got one. I was like, yes, but the doubling time is 3 days. 1,
mm,
2, 4, 8, 16. He's like, yeah, you're right. And I was like, yes, but that's so obvious, and yet it isn't. But the weird thing was you could do the math nationally and look at the PPE, and then great, you've just bought and raised money to buy 1 million items of PPE, and that sounds great. But the national requirement was 9 million items a day. And that's because we threw them all away. So we got an item of PPE, we used it once, we threw it in the bin.
mm.
And that immediately was like, well, no charity or no individual contribution other than massive government, and turns out to be slightly misuse of funds there, but let's not go into
Yeah,
that.
yeah, yeah.
Massive government procurement is going to
Mm,
move that needle in any meaningful way unless you think about the problem differently. So what became inherently obvious was we should build sustainable PPE. So we started with visors, and we ended up like raising money in a weekend. But interestingly, like all the founding mistakes again in the retrospect. So there's 5 co-founders. We were all related. Me, my wife, my sister, one of our best mates, and my wife's cousin, right? That was the 5 co-founders of that charity. The skills that we had as well, really underappreciated talent, but to name drop a few companies that people work for now, they work for Greenpeace, KPMG, Coca-Cola, Procter & Gamble. Like that was the team on the ground. Funny
mm,
enough, actually, my marketing guy here, Ed Terry, that's how I met him. He was working there at the time. So it's like, so the talent was phenomenal. But again, you
mm,
didn't know that because I'm a doctor and I don't know anything about anything at that point in my life, like especially in the private sector. You have no idea. So we just did amazing things, and I just was like, "Oh, this is just normal." We raised 3.2 million in about 2 weeks. We had
wow.
national coverage on ITV, BBC continuously for about 8 weeks. Delivered like 500,000 items of PPE in 3 months. Like just phenomenal effort. And that's because everyone's at home, no one's got anything to do, everybody really cares. Like mission and motivation is just locked, like it's a national crisis. It's so funny to think about, like, hey, that was like the perfect storm to start anything. The primordial soup of organizations, that was like as perfect as it
Mm,
gets. And doing all of that and going and learning what it was, it's like the ultimate CEO school in many ways, because it's like training school. Like it's so easy. Like recruitment's easy, raising money is easy, mission is easy, knowing what to build is
mm,
easy because like the acute need is there. We still made loads of mistakes, like managing people and fighting with co-founders, and now having no family and friends because I don't think I'm the easiest person to work with at the best of times. But when you're related, like you fight like cats and dogs, like it's really awful. Um, but it was just, but what was really interesting to me was like I finally found something which I felt like I could genuinely do forever, which sounds really weird,
mm,
doesn't it? Because it was like this short-term need that you're like, why would you think you could just found? It's like not founding charities or fighting COVID forever, but like this intellectual stimulation curve, like it just never ended. It was exponential because as soon as you solved these smaller problems, like how do we raise money and how do we set up a bank account and how do we, become a charity that's registered, which is really hard, by the way, would not recommend it. You have new problems of like charitable
mm,
governance and how do you set up trustees and how do you go and actually build the PPE that you said you could build and who's going to be accountable for that and how do you deliver that and what happens when you lose something. And I remember like once I'd have like media training in the morning and argue with the BSI about the thickness of plastic and why that's important for visors. And then, dig into some charity governance. And in the afternoon, go and do a BBC interview. And then the next day, I go do ITU and be the ITU reg for 3 or 4 days and then come back and do it again. So it was just a really wild time to do anything. But what was fascinating to me was I was like, actually, all of these things of like, being very quick to do stuff and making very quick decisions and sticking to them come hell or high water, which is obviously, impulsive and decisiveness together is often a bad combination, especially when you're very stubborn about it. Actually, in that environment was what was needed to be done. But for me, I was like, okay, this should be my specialty. Like even beyond AI, like building things and founding things and building organizations when it's new and having to figure it all out on the fly was exactly what I always wanted to do. But again, it's not an environment that you're ever exposed to as a clinician because everything runs on the rails, right? But it was interesting to me as well, was like, this is also unsustainable. So after about 6 months of basically building PPE and then wearing PPE continuously with 2 kids in the background, very burnt out, and I left. And then I became the chair of the charity, so I didn't really do very much day to day, and went on to pharmaceutical medicine, which was, again, a different field.
Yeah,
and
tell me a bit more about that, because you were a cardiologist at the time, and of course you moved into ITU during pandemic, but then you then took a bit of a change in your clinical career into pharmaceutical medicine. So what was the motivation for that? Was that related to the burnout, or were there other factors at play?
Well, I left my role, and then it's hard to leave your role when you have 2 kids and a mortgage. And my wife was like, you need a job. And I was like, let me go get a job. And I looked at some digital companies, and then this job came up, and it's quite interesting. It was sort of first in human gene editing studies at a pharmacology unit. Very interesting. Money was pretty good compared to your normal resident doctor pay. So I was like, let me give it a crack. And then actually turned out to be quite overqualified because I was quite senior. Most of the clinicians that come into that leave at F1 or F2, and I was leaving at like ST6. And actually they had a lot of need because they started to do very sick patients, especially like first in human, but in like cardiac patients who are generally quite unwell, as opposed to your typical patient who's like 20. And the very interesting thing about gene editing is like there is no first in human healthy volunteer studies because you have to have the pathology to benefit from having genes edited. So I think I was the second ever doctor to consent a human being for gene editing, like actual CRISPR gene editing. I think that's true. I mean, again, like it's just one of those claims that the company makes, but
Look, you've put it out in the media now, so it's got to be true.
Now in the world. But what was wild about that is like, that's just a flavor of how weird that job was, right? Consenting somebody essentially when there's no data in humans, and actually there's no animal data because you can't have animal data because it's gene editing and they don't have the genes. Actually, the guy was like, he asked a bunch of questions. I was like, we don't know. And then he went, well, I turn into a crocodile then, like really facetiously. I was like, probably not. Because what else can you say ethically? You don't know. It might be the I Am Legend gene mutation that we all fear. It might not be. But also, this guy was like so nonchalant, and he was paid nearly nothing to do that. But he was like, the second guy on the moon. He was like Buzz Aldrin, like so bizarre. I had to be so close and yet so mundane. It was very interesting. But I think what the other thing was like innovation in private companies is like nothing you've seen. If you're in the NHS, getting close to cutting edge work is quite hard, and it's all academic and there's loads of politics and you wait 18 months for funding. But this particular organization was like standing up gene editing trials in like 8 weeks. Like it was executing at this level that I've never seen. It was like hella impressive how they were just figuring all this stuff out on the fly and doing it properly. Like, hundreds of documents, planning stuff, running it like an actual like military industry. And I was like, I've never seen execution like this. I didn't even know this existed. But also in a regulated way. And that was a really interesting experience for how we run at Tortus, because I'd seen that you can do a clinical trial in 8 weeks if you know what you're doing and you're super organized and you have the protocol written and you've got it all, and you can make a well-oiled machine to do that. But then the evidence that you generate in that space is super solid, but and delivered on time. There's a really interesting trend at the moment about this triangle, right? About cost, quality, and time. Actually being a sort of urban myth, because if you think about it, like the very best builder that you ever had didn't cost the earth, did amazing work, and did it under time budget or even faster because they were just really, really good at it. Or when you watch, an expert surgeon, for example, they are really quick and they're really good, and therefore more cases, so the cost of the list goes down. That's what expertise actually looks like. And this was a very interesting mindset to me, that actually there isn't necessarily this trade-off. If you go right to the top of your game, you see people just ignore that entirely and just like figure out ways of delivery which are, beyond the expertise and in terms of what you would normally get. So it's a very educational experience, if nothing else. And the other funny thing, and this is going to make you laugh, I got promoted 4 times for doing good work. Can you imagine? Like, I did good work and they promoted me. And I was just like, what? And you were going to pay me more money?
Culture shock.
It was like a culture shock. I was like, and you pay me more money for my good work? Like, what? Are you sure this is what you want to do? It was so funny because, like, the private sector is just traditional, how the rest of the world is living, right? You do good at your work, they recognize that, they promote you. And in the NHS, obviously, we have this like time-based system, but actually that does index very negatively sometimes when I do all of this and I just rock up same salary and the same pay as everybody else. And actually some people do some things that are egregiously on the other end and they're just still there in their job. And that I think that actually does really grind people down. And increasingly, you think about talent now, and especially in a startup where it's hyper competitive in AI, how you manage your talent density in a company is extremely important. And, no one's actively managing anything in the public sector. And that's unfortunately the way it works. But in the private sector, it's like an education in and of itself about how much people index on performance and pay and promotions. And there's an edge to that, and there's politics, and there's pharma money, and there's a lot of dark side to it. But yeah, it was very educational to see how a private company can operate, and can operate for real good, which was really interesting. So there's a bit of a sideways change into a different industry for a while. And I had another number as well. So I had a cardiology number, gave that up, pharmaceutical medicine number. And I remember like spending a year and a half nearly to get that number, thinking that was for me. And then basically in my first meeting, they were like, okay, now open up your e-portfolio. And it was the same e-portfolio that I just literally abandoned 2 years ago. And I was like, oh no, what have I done? I'm back here again. It was probably like the sequel to some horrible movie where you just end up back in jail. It was like Prison Break Series 2, where he's just like back in prison again, but it's a different prison. And I was like, oh my God, I've made a real mistake here. I was really enjoying the freedom of not having to do portfolio work and like being treated like an adult. And suddenly I'd infantilize myself again with the same nonsense. Yeah. So yeah, I made some mistakes there again, for sure.
Now, I'm itching to talk to you about the journey of Tortus, but before we move on to that, just wrapping up the topic of pharmaceutical medicine, are you still maintaining your number? Are you still doing things in relation to pharmaceutical medicine?
No, I gave that all up, and I think there was a path there that exams to take, and you could become a clinical trial physician and do lead research or QA or regulatory affairs. But it's too hard to maintain. And I think the one thing I would say, and this might be a controversial take for this program, and I wonder what your take is, because I think you might agree with me. Generally, medics are actually pretty good at starting companies if they're that way inclined. There's lots of transferable skills. The biggest single failure mode I see is that they don't jump in with both feet. They tend to do it on the side. And some people are very successful doing it on the side, don't get me wrong. But you always wonder, like, if you're that good at running this thing 8 hours a week or 12 hours a week and then doing your day shifts, what could it have been if you just jumped into that 100% and just given it your all? Because actually, medics, we're used to working really hard and all hours and responsibility. There's loads of great stuff in there. But making that jump out, and what was interesting for me is like I left, COVID, sort of very extraordinary circumstances, ended up in one role. So when I moved into Tortus, I could move like full on, but then I couldn't obviously commit and keep my number and maintain all of that. So I do my revalidation, and I still try and do some locums to keep my hand in clinically, because I think that is quite important. But I gave the number side up.
I think I definitely agree with a lot of what you described, but I would caveat it to say that it depends on what you're doing, because I think for you and I, we founded, venture-backed businesses. We're going after huge opportunities and trying to build platforms. And for those kind of businesses, then inevitably the founders need to go full time. And I've seen it where there's some who found businesses that could go to that level of scale, but they can't give up their clinical practice. And of course, they're going to be at a disadvantage to the people who are working 996 on their startups. Like, that's just an inevitability over time. That's when you're going to get the delta in outcome. But then on the other hand, I think there are clinicians who start businesses that are subscale that can simply not grow at the pace that a venture capitalist may expect. And actually more time in the business or in the innovation won't necessarily change the outcomes. So, I mean, that's my nuanced take, and that's certainly the party line for this podcast. But I think in the case of you and I, it was always inevitable that we needed to go full time. I resisted going full time for a long while. So when we founded Patchwork, Anas and I still wanted to finish off my foundation year 2 because I took my year out between F1 and F2. But that was unnecessary, really, and maybe actually detrimental, other than saving on the burn a little bit. And even when I left, both Anas and I continued to locum because we were building a locum platform, but the operational demands of the business were just simply too intense. It would have been at the detriment of scaling the business. So I think in that respect, I do agree with you.
Yeah. And I think you're right. Like, what are you setting out to do? In the venture world, and maybe many listeners don't know this, but because of something called the power law, the way that they invest their money is that, say they have £100 million, they'll put £1 million into 100 companies, but each of those companies has to have the potential to return at least 300 million to the fund. So if you do the math in terms of percentage ownership, each of that £1 million actually has to come back at £1 billion of value to make the fund mechanics work and for their investors to get a return. So they invest in these moonshots, but they invest in 100 moonshots with the expectation that 99 or 98 will fail, one will break even, and one will basically return the whole thing. But each of them has to be pursuing and shooting for the moon. And therefore you do need to give it your all, because somebody else who's got that capital and the resource and was spending not their time to do that. I think bootstrapping it or doing it slowly is very possible. I guess it kind of depends what the motivate. If you want to, just have a slightly nicer life, but you're happy with your work, then by all means. One thing I would say is, like, being extremely ambitious is easier, paradoxically, than being moderately. And it's that thing about, shoot for the moon, land in the clouds, or, shoot for the ceiling and you probably won't even do anything. And that's probably not the phrase, and I can see why it doesn't come not particularly eloquent. But I think the point is, like, yeah, but if you set your company up that we're going to be a global company, we're going to hire the best talent, we're going to raise money, then at the very least you're probably going to dominate your local market if you're giving it your all. But you are giving it your all. Whereas a lot of people really stress themselves out in terms of passing their time into basically nothing, and they spend their time not making progress in their career because they're so stressed out with their business, and not making progress in their business because they're so stressed out with their own calls and their career, and then family loses it. So in many ways, for me, and I've got 3 kids now, jumping in to the business full time might seem like an insane thing to do for a father, but in fact, from clinical land, where I'm on call 8 to 8 and there's nothing I can do about that, I have to be at the hospital, doesn't matter who's sick or what people need or what shows are on or like all the other accoutrements of being a dad. Whereas in my job right now, I have full autonomy. I do every bedtime, every pickup, every show. I don't think haven't missed a school assembly for like 4 years. And that's because I have full autonomy. And again, I think people miss that piece, is like, yes, you have your stable income, but that stable income is in many ways a trap. Whereas in fact, if you were over here and you were driving it yourself and eating what you kill, you might kill a lot more, and to get to mix messages.
love these analogies.
But like, actually eat and make sure that you do make a wage that pays the mortgage and pays for your kids, but you have full control over it. And I think, interestingly, lots of entrepreneurs in medicine will come out slightly later in life than maybe some of their counterparts did. And you will have dependence. But the paradox is you might actually find that you have more time to them as a consequence of having your own startup. So I do work 16 hours a day, and I'm sure you're the same, but I fit those hours in to my family. So after, before, during the commute, etc., etc. But I can still go and do pickup. And I think that is something I've only really started to appreciate in the last 1 or 2 years, is that the flexibility I had compared to how we used to work just seems insane. Like, me and my wife both
Yeah.
did on calls for a period of time. I didn't see my daughter for like 2 weeks when she was like 1. That's crazy, isn't it? Like, day on call, night on call, she's asleep, I'm awake, etc., etc. So yeah, there's a lot to be said for jumping 2 feet in, and it's not just about security. In fact, it's about freedom.
Yeah, the freedom and the autonomy. So, on the subject of jumping in feet first, let's talk a bit about Tortus. So, how did that all come about? What inspired you? Like, what was that early journey? How did that look?
Well, I think it's funny. I often do an intro to Tortoise, and I have this email that I wrote to Cerner, which is now Oracle, in 2017. So I was doing a ward round. First time we used a computer system, in fact, a cow to do a ward round. I think we were on some paper notes before that. And I was like, yeah, it's a great system. I was being polite. It wasn't a really great system. But it is slowing us down by about 25, 50%. And wouldn't it be great if you could streamline it, remove the cognitive load of all of these buttons, thousands of which I don't press, to just the 3 things I actually want to see on a patient basis, which is their bloods, their notes, and then I want to see their imaging, and then I want to document and that's it. That's all I actually want to see from the computer. And I wrote this email. I was like, you should build this. And then actually they did come out with Cerner Touch a few years later. And I don't know if that was my idea or not, but ideas are cheap and execution is everything, as they say. And there's definitely a lawsuit in there, so I'll lean away from that. But I think it was always this existing frustration that, and this is almost a definition of moral injury, right? Like, I'm running the heart attack service, let's say. Patients are literally coming in cardiac arrest. Many of them don't make it. That's just the nature of that service. And I'm over here on Cerner, like, trying to document and getting stuck and a pop up, and then another one's coming in. I've got to run over there. So you're constantly stressed between the computer work, which is this very high friction. In fact, now it's like 60% of an average clinician's time. For a resident doctor, there was a study, very good study in the BMJ in the summer. 80% of their time is spent doing computer work. And you can kind of see why, like, burnout is super high, morale is super low, strikes are always happening. If 80% of your day post medical school is just typing on computers and doing basically medical administration, you can see why lots of the juniors are super frustrated. This is not what they signed up to do. But in the world of AI, the concept is, well, couldn't we just build a better interface that still serves the system, because those electronic systems serve a very important system basis, potentially with better data, but relieve the friction, the frustration of the resident doctors and well, any doctor or any clinician, in fact, using the system. So it always was about the interface. Now, the interesting thing about Tortoise is when we first started, we had a very high tech solution to that, which was essentially to build an AI interface that could control any computer. And that would solve interoperability, and it would solve a bunch of other issues along the way. And in theory, that could be your resident doctor, but everybody's got one that's typing and filling in and using any system. And transpires that, A, extremely hard to build technically outside of a foundation lab. B, the foundation labs will build it anyway. And C, it was never robust enough, even now, right? 3 years after the fact, and I can spin the same technology up on my computer. I can code it myself now, using like off-the-shelf stuff. But it's still not robust enough and reliable enough to, be reliable to prescribe a prescription accurately, or to order the right blood type in an emergency, or to document. So there's this robustness issue. And then the last point was, like, we sell to hospitals, and hospitals don't like this technology. In fact, many of them are contractually allowed to not use it. So the thesis was correct, but actually it was interesting that the value between the tools that the AI system would use and the interface, actually, once we integrated, the interface issue disappeared entirely, and it was only about the value of the tools. But we built AVT 3 years ago. It took Chris and I, my former co-founder, a week. We thought the technology was too easy, if I'm honest with you. It was too easy to build something that was robust, and therefore it will commoditize, and therefore it's not worth investing lots of time in now. And that was completely the wrong take, because we could have made that market. We could have launched Heidi in the UK a year and a half before anyone had heard of Heidi. But obviously we would have found the same issues with, like, hallucinations and emissions and all the safety stuff. So we made a decision to go slow and collect the data, and really build the evidence behind it. And then over time, realized that the focus was on evidence-based medical device grade tooling that can be used in the clinical setting in a reliable way. So what we did is we mapped the workflow. What does a clinician do? They find information, they document new information, they act upon what they found. So those are the three buckets of any clinician journey on any computer system. Launched AVT to enterprise about 18 months ago now, done very well. Loads of hospitals, loads of primary care in the UK. And now working on those other buckets where we're going to look inside systems. So today, actually, we've just interfaced with EMIS and TPP in secondary care, where most of them now Epic and Cerner. And that gives us access to the database and be able to summarize and to take actions in that system. And then sort of building from there, really, what we can do next for that clinician workflow.
And you said you started, you launched the first product 3 years ago. And you also mentioned as well that it was hard for organizations to analyze the risk when it came to AI, certainly back then. I mean, nowadays, AI is having its moment. But how did you go about getting your first customers, especially those in secondary care?
I think the honest answer is I don't know, even to this day. So our first major partner was Great Ormond Street, and it's well documented in the public domain how much work we've done together in the last 3 years. But when we first went there was just me, Chris, and a laptop. We had a prototype. We built the prototype. We worked with their Drive unit, which is their innovation unit. And I remember going to see Shankar in there, who was their CCO, great guy. And he sees like rubbish all the time. So he was just like, "Oh, what's this rubbish? Who are these like randos? Let me break the system and make them cry." That was like I watched him try to break it, right? And when he couldn't break it, he suddenly flipped. So I think the one thing that I've learned very, very, very clearly, the biggest cynic in the room, if you can convince them, will always become your biggest champion. There's something about the journey that people go on that keeps the momentum going. And we've seen that very consistently in nearly every deal that we've done since. Find the person that's just like, who are these guys? And just talk to them about, here's the safety system, here's the proof, here's the evidence, and we've thought of that, we've done that. And suddenly they realize that actually these people do care. And I want to go on the journey, because the cynics are always the ones that care the most, ironically, because they see every way it can go wrong. But if you can convert them and you can become a great champion. And then the other interesting thing about Great Ormond Street, because it is such a highly sensitive environment, the bars and the barriers that we had to go through kind of set the standard for this technology, right? So we ran the only today clinical trial in the country, and maybe in Europe, like a proper actual clinical trial of AVT. We used some of the pharma methodology. So we did a phase 1, which was a full sandbox, a phase 2 with real doctors, but fake patients, so no clinical risk, comparing the technology, looking at the quality, the accuracy, the productivity, the time save, published that. Then we did a phase 3 feasibility study, so very much like you would the first in human, where we just see what patients think about this, but again, in a very highly sensitive environment. And then we got some money from NHS England to do a phase 4 study. And the phase 4 was multi-center, 9 different sites in London, outpatients, A&E, and a bunch of other places. And actually that was the transformative proof that is now in the 10-year plan and has proven out AVT for the country. But what was really interesting about that is we just kept doubling down on what seemed to be a very good way of proving, the risks and the technology. And the one thing I've always felt about health tech is people think that clinicians are slow to adopt and enterprise is slow and hospitals are slow, and not really. If you can prove it and you come to them with something that they need or they want, like productivity, for example, and you can prove it and you can prove its safety, then people adopt almost instantly. I remember as a cardiologist, I would change my practice significantly overnight sometimes. For example, we were prescribing warfarin for AF when I first started. Midway through, the first DOAC started to come out. Initial data wasn't great, but then the ESC guidelines changed and suddenly it was routine practice. Pixaban, rivaroxaban, edoxaban flying out the door. And towards the end, we started prescribing it for heart attacks because, again, the ESC guidelines had changed. No one asked me to do that. It was just there was a standard of evidence and it was met and it was the best thing for the patient. And that was that. And then that went out the door. And our approach at Tortus is exactly the same to health tech. Like, why should it be any different, to be honest? Like, prove it's safe, prove it works, and take the time to prove it. But once you have, and this is what I'm trying to lobby government on at the moment, get out of the way, because it's technology that the system needs and has proven value. And then we just go back to the drawing board again and be like, hey, what's next? And then we take it through that system in the same way. And it's slower, but we think ultimately that is what is sustainable. And that's a big reason why we decided to call ourselves Tortus.
Brilliant. And I want to ask specifically as well about fundraising, because I think most health tech entrepreneurs struggle with fundraising because, to your earlier point about the power law and around the expectations of growth, there's almost there almost certainly is a friction between the pace at which a health system moves in terms of adopting systems and then the lag time in terms of generating revenue versus then the growth expectation that many VCs will have. But as I mentioned before, AVTs are having their moment, and the company is an AI solution when all the venture capital money is going into AI at the moment. So how has that been for you?
Yeah, it's really interesting. And I think fundraising it's one of those things that on the face of it sounds like go out, raise money. But actually it's like a funnel, it's like a sales process like anything else. And there's a few things that I've learned that have been really helpful. So there's this Paul Grahamism is like, okay, number one, who is the biggest investor in your company? You are. So there's no point trying to fool investors, because ultimately you are the biggest investor in your company in terms of your life cost opportunity. So if you are going out and not believing what you say and not believing in your own investment, then the only person you're really conning or taking the mickey out of is yourself. So I think the first thing says lots of people think it's like go out, get some money, have a great time. That's not the point, really. You're actually borrowing money. That's probably a better mentality of how to think about it. Like you owe these people an outcome because you owe yourself an outcome. That's what you're going to do. And then the second thing is often, especially in VC land, it's not their money. They have a thesis, they have a operating model, they've raised money from their own LPs. That's the fund. Their fund has a life. Really understanding the mechanics of, okay, you're writing this check, but why are you writing that check? And why do you believe in us? And what is it that you're looking for? So one of the things I was doing when we were raising seed was I try to spend the first 50 minutes just asking the person across the table from me, what are they looking for? How do they sit in that seat? What is it that drives them? If someone says, I'm looking for X, Y, and Z, you just say, well, we do X, Y, and Z, right? That's very straightforward.
Yeah.
And if you generally don't do it, it's like, well, that's not us, right? Sometimes people go, yes, we're looking for Series A companies that are doing 10 million revenue. And I was like, well, at the moment, we're seed stage, so we should probably just not waste each other's time. And that was a very easy way to quickly invalidate that funnel. You obviously need to do a lot of research. But I think there's different fund types that invest differently. So angels, for example, they just take bets on the team. They really don't care about your idea even that much, although they want to see that you're smart and motivated. Whereas now seed stage is increasingly about traction. So you have to demonstrate, that you can sell, and you've got even probably revenue at this point because AI has changed the rules again. Series A is about growth, and have you got the traction? Have you got the money? And actually, is there a clear growth plan for how you're going to win that market? And Series B is just about scale. You have to show that you've built the machine. It just needs capital in here. You need to pour it in. And there's different investor types for each of those models. There's also other forms of money. There's venture debt, there's equity, there's a loan. So if you're bootstrapping a company, there's no point going to a VC because you are trying to not have a great outcome for them. You're trying to change your life meaningfully. You might exit your business for 5 million and you own the whole thing, and it'll take you 10 years to do that. But actually from a VC perspective, that, although it's funny enough to say this, is a complete fail. If they give you 1 million and they get 5 after 10 years, their fund fails and VC again. So their reputation is really important, that you blow up and you blow up in a good way, in a very big way. So you're going to the wrong investors if that's your life plan. I think that's the commonest mistake I actually see is people think money over here, I need money, right? And we're just trying resources, when really you need to think about, well, what are you going to achieve with that money and on what timescales? And that will tell you where the market is. And then you generate your funnel based on that. Just like in any sales motion, again, all things that I've learned over the last 3 years, when we first started, we sold to everybody and every type of clinician. And that was a mistake because everybody thinks and needs slightly different things, or sometimes very, very different things about what they care
Mm.
about, distribution channel, or how you reach them, or the message, or your competitor profile. And it's the same thing with raising money. You're essentially running a sale. What's that handbag that you can only buy in New York if you're on the list? Do you know what I
Oh,
mean?
the Birkin, the
Yes, right? So like, if you're a purveyor of handbags, that particular model is so stupid. Like, why would you stop people buying your handbag? But if you're selling the most exclusive handbag in the world for like £10,000, ironically, the only people want to buy that are the ones that mean that, X hundred people couldn't buy it. And that's what makes it valuable. So you construct your funnel around what your product is. And it's exactly the same thing with selling equity, which is what you're doing in your company. Who is actually the perfect customer for you and why? And sometimes, VCs will be like, oh, we want this partner because we work with them and we offer this, this, and this. I don't necessarily think anything that's true, but certainly alignment on what the vision is and what you want to do. So for me, I came out of EF. We drank the Kool-Aid early. They're like, you're going to build a company, and I'm like, nah, we'll do 1 trillion. And you really do want to like go as global as you can, as big as you can. So then when you go out to tier one VCs, that's the story that they need to hear. That's the story that you're trying to achieve together. And that's where you raise big rounds. But the big rounds, if you're not going to use that capital to have big outcomes, are actually going to weirdly hurt the business, because you all need to scale in a way that you might not feel comfortable with or be ready for if that's not your global ambition. And therefore, actually, that capital can be harmful. And people often miss that as well. Like, more money is not necessarily, literally is more problems in many ways. And sometimes it's not the right way. So having a clear vision about what you actually want to achieve and why is so much more important than how much money you raise and when. And I think that's the piece that, second time founders get it. They know exactly when and where to raise and who for, because they've made all the mistakes about what didn't work.
For sure. No, really interesting to hear all that. And I can imagine coming out of EF, you probably had a lot of options. And as you said, drinking from the fire hose. Many top tier VCs were probably interested in speaking to you at the time. So then we're coming to the end of the show. I wanted to ask, what's next for you? What are you most excited about in the coming years?
Yeah, I think what's interesting for us is what are we building, right? And to go back to my point about the interface, what does it actually mean that the computer in the room understands? And I mean, it understands human prose, it understands natural language. So suddenly the ability for the system to access and understand and interact with on a machine level capability, like the computer itself can listen to the patient clinician consultation, surface all these system level insights and better care navigation and automation, etc. But really what we're saying now is like the patient clinician in, bipartite relationship is becoming clinician, patient, and AI. And how the AI interacts with the clinician, which is what we're doing at the moment, or in the future, how that same AI could interact with the patient and become a true third partner to both at a system level. I think that's very exciting. And we're starting to see the early inklings of that now. We're doing things like guideline decision support for the clinicians. We're starting to do patient communications and already starting to use that loop of like, well, the AI could rewrite your letter for the patient. You don't need to have the clinician choosing who they're talking to. They could talk to 2 audiences simultaneously. Seeing that sort of patient engagement and that impact. I think the other critical thing that I'm just super excited about is the scale of impact on colleagues. So the first time we shipped, we got some feedback from the first user about 2.5 years ago now. And he's like, Tortus has changed my life. I went home 15 minutes early today. That was the first user of Tortus, right? Nobody had ever used it before. He was like, this is transformative. And actually, I remember thinking, job done, right? One clinician, their life is better. That is job done. Everything else is bonus from here. And where we're at the moment is just like, well, how far can we push this? How far can we alleviate a lot of the morale and burnout and issues that we're seeing in our profession at the moment? And even in the short term, I think what happens in the next year is going to be insane, because everybody will start using this tech. And then hopefully, from a safety perspective, we've sorted all of that. You start to see real changes in the system, changes in morale, changes in productivity. And then beyond that, like what happens when the AI starts helping you and supporting you in your consultations? That's when things start to get really interesting and exciting. And how do we make sure that we do that right? And we don't create reliance biases or sat-nav type problems for doctors, and we actually upskill them instead of de-skilling them. And these are all sort of the academic challenges and really interesting stuff with human factors when there's an AI in the room, for example. And how do we start delving into that as soon as possible? And I think that's going to be awesome.
Brilliant. Well, that's all the time we have for today. Thank you so much for joining me, Dom. And for those listening, if you like what you hear and want to support the show, please do like and subscribe to us on Apple Podcasts, Spotify, YouTube, or whatever podcast platform you're currently listening to us on. It would mean a lot to me, and it would really help spread the message to others exploring alternative paths. Thanks for joining, and see you next time. Bye-bye.